We first heard the regional view, and now we heard about from a country who is already in the process, very advanced in the elimination, and the focus for them in the vector control is really surveillance and prevention of reintroduction. So it's very nice to see these examples at different stages in the process. Now we're going to hear from Dr. HeleneHiwat, who is the coordinator of the National Malaria Control Program in Suriname since 2015. And before that, she was the head of the entomology program in Suriname. So thanks.
Thank you. Good morning. Before I'll start, I'd like to explain for those people who are not very familiar with Suriname, where Suriname is. It is actually in north of Brazil, in between Guyana in the west and French Guyana in the east. It is an Amazon country with about 550,000 people, and about 90% of these people live in the coastal area of the country. So we'll discuss Suriname as an example for vector control strategy and decision making, guided by the changes in transmission risk area and risk population. And secondly, we'll discuss the current challenges the country faces on the road to malaria elimination. So what's happening in Suriname with regard to malaria? The coastal area has been malaria-free since 1968, but we had continued transmission in the tribal villages in the interior of the country, with very high incidences at the beginning of the millennium. And then between 2004 and 2007, malaria in Suriname decreased to elimination level following a number of interventions, including the introduction of artemisinin-based combination therapy for falciparum malaria and the free mass distribution of impregnated bed nests. So the remaining transmission areas were linked to gold mining activities, and after the elimination in the villages, the gold mining, the mobile migrant populations became the new priority risk areas in 2009. And then the Ministry of Health, with support of donors, adapted its program to address the malaria in the remote mining risk areas and in the migrant population. And it was successful in further reducing the malaria transmission in Suriname. The mobile migrant populations, however, were not only moving within the country, but also across borders, and especially to the illegal mining areas in French Guyana, where malaria transmission is still occurring. So the new challenge for Suriname is the continuous influx of malaria from these mining areas in French Guyana. The next slide shows the evolution of the autochthonous malaria between 2000 and 2017. We had a decrease of 99.5% since 2000, and the number of cases in 2017 was 40. You see the very steep decrease between 2004 and 2007, which was the elimination of malaria in the village community, followed by the slower decrease in the mining communities. So which were the primary vector control interventions? Well, our main vector in Suriname is Anopheles dahlingii, and it breeds in swamps, along the river sides, and in creeks, and it's not an option to work with larvicides for these mosquitoes. So the accommodations of the village people allows for indoor residual spraying and also for bed nets. So that's what we did. Little interventions were done prior to 2006 as a result of very limited national resources and human capacity in terms of transmission prevention and vector control. But then we got our first Global Fund malaria program in 2005, and the opportunity arose to develop the vector control measures. And in 2006, indoor residual spraying was done in the high-risk areas. After many decades in which indoor residual spraying was not done. And in the same period, between 2006 and 2009, there was a mass distribution of insecticide-treated nets in the village populations. That was followed from 2009 onwards in the mining areas, in the risk populations in the mining areas, especially along the border with French Guiana. So let's first look at IRS. It was initiated in 2005 and 2006 as part of the Global Fund project. The investment in setting up the IRS in a country where there was no trained human resources, no equipment, no insecticides, and no roads toward the risk population and risk areas was considerable. People of the villages themselves were trained and employed to do the work, and lots of work went into outreach, community engagement, and setting up the monitoring and evaluation system. But then, because of the decrease, the very steep decrease in 2006 in the number of malaria cases, we had to discontinue IRS because it was a matter of cost versus benefits, and it was not feasible to continue with IRS in that situation. So, it's much more easy to distribute nets than to spray. There was a history of the production and distribution of bed nets in the village communities as part of a cooperation between the Medical Mission, which was an NGO responsible for primary health care in the villages, and the local women corporations. So between 2006 and 2009, the long-lasting insecticide-treated nets were introduced in the village communities, and this interrupted the production by the women organizations. But then afterwards, especially in relation to the outbreaks of chikungunya and Zika in Suriname, the production of bed nets by the women organization was restarted. So the first impregnated bed nets that we introduced in the communities were not well received. They were too small, they were white, which was not appreciated, and they couldn't be used for both beds and hammocks, as was the case for the nets that we produced with the women organizations. So we had to do something, and what we did is that with support from the donor and the producers of the nets, we adapted the nets to a larger model that fits both beds and hammocks, and changed to darker colors, mostly green, instead of white. So the new model, we called it the sexy bed nets, was in very high demand, and distribution was combined with an outreach campaign, and retreatment tablets were provided as well. So since 2009, the distribution is done in high-risk mining areas in the remote forest during the ACDs, the active case detection surveys, and also at the malaria program service points. So what happened between 2004 and 2007 when we had this steep decrease in number of malaria cases? Well, the introduction of the new treatment for falciparum malaria was an important factor, since over 80% of the cases in Suriname were the result of falciparum infection. But the combined effect of mass distribution of nets and the IRS in the high-risk areas was thought important as well. At the same time, in 2006, we had a massive flooding of the villages in the high-risk areas. Villages became flooded. There was a lot of people movement. So the fear and the expectation was that there would be outbreaks of malaria, and that the mosquito populations would thrive because of remaining water bodies in the swamps and along the river edges. So the opposite happened. What happened is that the mosquito populations collapsed, and the idea is that maybe as a result of the repeated flooding of the larvae from the area, and also the impact of the IRS and the bed nets on the adult mosquitoes have really crashed the mosquito populations. And that was good for us, but we moved from the village stable populations to a new risk population, and those were the mobile migrant gold mining populations that were almost completely Brazilian, from Brazilian origin. So we had to deal with a population with another language and all the culture, often undocumented. And because of their mobility, there were different living conditions as well. So what to do with vector control? Well, the mining areas were very remote, isolated. The miners were living in open camps, and they were traveling continuously. So actually the only prevention and person-based vector control that we could provide were the bed nets. But dealing with bed nets in mobile miners brings a whole set of different challenges with it. There is the remoteness of the risk areas with high logistical costs, because we had in these areas a gold-based economy. The miners have little patience for anything to do with health, because time is money and travel to health service providers costs money as well. And also in Suriname, malaria is almost non-existent. We are almost to elimination. So why would you invest in malaria prevention and control? So as a person, so there is also for management reasons, there is a challenge of not being the data not being available about the population size, the population mobility, the turnover, and the priority health needs of these migrant populations. And the high turnover rate means that in any given area, you're constantly dealing with new people. So this impacts the interventions, especially if you're talking about bed nets. And I'll show that to you in a minute. And last but not least, there's a risk to health workers to work in these areas, which are mostly non-regulated, and logistics are dangerous as well. These are some pictures just to show you the challenging situations in these mining areas. The population is for a large part working age males. There are women and children, but not a lot in the mining areas. So one of the challenges is risk perception, especially if you want to work with bed nets and have the people use the bed nets. It's important that they are aware of the risk. But we see that over 93% are not at all or only a little bit worried about malaria in these areas, and they have reasons because a large proportion of them never experienced malaria or hasn't seen malaria in the last 7 years. So this confirms the elimination status in Suriname, but it is not very helpful when you want the people to use the bed nets. So as a malaria program, we'll have to be very creative in trying to get the people to use the bed nets. And for instance, blood-sucking bats can be a good motivator to make them use the bed nets, and we're not afraid to mention them. So there are many more challenges for coverage and use in mobile migrant populations. Nets are lost during traveling or left behind as excess baggage, as only the bare minimum is taken along. And the people working in French Guyana have the added risk that if they are apprehended by the French military police, all their possessions will be burned, including the bed nets. So there are also reasons for not using the nets. There are no mosquitoes, there is no malaria, it's too hot, and also it's a barrier for escape when you're dealing with the police or potential robbers. The effectiveness as a protective measure in some mining areas will also be impacted by the 24-hour shifts that's happening in some of these mines. So that leaves the miners exposed during transmission hours. So again, some images of the work being done in the field in Suriname for the bednet distribution. In the top left image, you'll see the all-terrain vehicles that are being used to transport the bednets to the remote isolated mining sites. And to give you an impression, I talked about the gold-based economies in these localities. So for these ATVs, if we rent one of them during the day, a whole day, we'll have to pay the equivalent of 10 grams of gold. So it's very expensive, and this is one of the many reasons why Suriname is still very much dependent on external support for this intervention. So, as you know, the bednets, the impregnated bednets especially, are core interventions for malaria prevention according to the WHO, and universal coverage is recommended. But the experience in Suriname taught us that reaching universal coverage in mobile populations, even when doing mass distribution, is virtually impossible due to the continuous movement and turnover of people. So this is, in our context, especially true for the cross-border moving populations who travel to and from French Guiana. To give you an impression, we did a CAP, Knowledge, Attitude and Practices study in 2016 among the mining populations along the border with French Guiana, and found that despite distributions, the ownership was only about 40%, and the usage of LLINs was less than 12%, which is horrible. So we did a new CAP study last year, but did not only include the border miners, but also the miners in the central area of Suriname and the west. And we got other numbers here. The ownership is still far below what is expected, but the usage rates is much higher. Overall, women are always doing better than men, but as I told you before, the majority of the people in the mines are men. And so these studies show us that the practices and attitudes toward bednets differ between the different mining populations. So we have to distinguish between the cross-border moving miners and the miners that more or less remain in the country. And we'll have to adapt our programs accordingly. So what we need to know is that with all these challenges and the successes in the bednet use and coverage far below expectations, does the intervention pay off, or are we wasting time and money and effort that we could use in another way? And especially invest in one of our other core interventions, which is that we engage with the risk population and train people in the mining areas to provide diagnosis and treatment to their peers. And we have a whole network of these people, calling this the Malaria Service Delivery Network. So that is an important intervention that's proven successful. So are we wasting money here on bednets? Well, not completely, because it turns out that not all is lost. The CAP study of 2007 shows that over 3/4 of the people in the mining areas who actually use the net receive the net from the malaria program, and over 80% of the people who had received the net from the malaria program are actually using it. So our biggest challenge now remains the cross-border moving population. I told you that we had 40 cases of national malaria cases last year, and in addition we had 511 imported cases, which for the major part were originated from French Guiana, but these were the miners. So these were the Brazilian migrants moving between French Guiana and Suriname. So what is happening in French Guiana? I urge you to read about this. There are a number of publications, and one of them is from our esteemed colleague Mélisse Douin from French Guiana, who's here, explaining that the migrant gold miners in French Guiana are a huge reservoir of malaria with a high transmission potential. And the prevalence of Plasmodium in these areas can reach up to 40%. So the risk of these hotspots of malaria in the region are that in the absence of diagnosis and treatment in these mining areas, there is improper self-treatment, use of black market drugs, and this increases the risk of artemisinin resistance emergence. And of course, there is the risk of larger outbreaks in French Guiana itself, but also in the region in the Guiana Shield. Unfortunately, due to French policy and legislation, French Guiana is not in a position to deal with malaria in the illegal mining areas in the same way as we are doing in Suriname by engaging the risk populations themselves. So in an effort to help the people in the mining areas in French Guiana, and of course to prevent further escalation of the problem, we as countries, Suriname, French Guiana and Brazil, have started a pilot study in which a self-diagnosis and self-treatment kit is provided along the Surinamese and the Brazilian border of French Guiana for those miners who are actually traveling to the French mining areas. More information about this pilot can be found online. It was published also. And despite this discouraging results that we had in the BedNet usage in this specific population, we're still distributing the nets as well. So in conclusion, there is near elimination of malaria in Suriname. We have adapted our vector control strategies over the years to the context for maximum cost-benefit effect. Mobile migrant miners remain a challenging population, especially when we're dealing with the distribution of the prevention and distribution of bed nets. And then we have the remaining malaria hotspots in French Guiana that are an important threat to the elimination objective in Suriname. And we hope that France will work on an effective intervention for this problem. We have some recommendations here. Taking into account the adaptive vector control interventions in Suriname over time, we recommend the countries to keep evaluating their prevention and control programs on a regular basis and to adapt these where necessary. And considering the complexity of prevention and use of bed nets in migrant populations, we recommend for WHO to provide guidance on the prevention and LNIN strategy in mobile and cross-border moving populations. And this is important for us as a country because we are funded by the Global Fund, and the Global Fund is looking to the WHO to tell us what our goals should be. So if the WHO tells us that we need to reach 100% coverage in mining populations, I know that I'm never going to reach that goal. So I'll always be underperforming. So maybe the WHO can provide some guidance, what should be the priorities here. And then last but not least, taking into account the situation of the hotspots in the French Guiana and the risk that it brings with it, we recommend for countries in the region to work together to ensure provision of free malaria preventive tools, diagnosis and treatment to all persons at risk in malaria transmission areas, independent of legal status and activities. So I'd like to thank the Ministry of Health and the Medical Mission Primary Healthcare Organization for their work, and of course our donors, especially the Global Fund, who made our interventions possible. Thank you.
Thank you very much, Helen. I've been working with entomologists for a few years now, and they're an interesting group of people. Who would think a bed net is sexy? But that's the kind of people we deal with. So we do have time for a little bit of one quick question. Please, go to the microphone. Yes, please. And as good Latin Americans, we are running late, but we will, we do our best.
I tried.
It's not your fault.
Let me first start off by saying that my mother is actually from British Guyana, so I knew about Suriname, right?
You're not allowed to say British Guyana anymore.
Okay. Well, okay, so Suriname was independent in 75, right? From the Dutch, yeah. So British Guyana was just the year I was born, actually. So I'll say no more about that. Helen, fantastic talk. Congratulations on the Malakit pilot as well. I think any change program that is attempted is always held back by behavioral change. Yeah, it's the behavior piece that is such a challenge. And, getting a constituency or group of people to change their practice, clinicians with clinical practice, laboratories with laboratorian practice, people in an elimination program when we want to drive towards zero indigenous cases, but also prevent reintroduction in those areas. It's all hinged on behavior. Just a couple of comments. I think the advocacy group Malaria Don't Know More, they actually put out a piece about malaria being bad for business, so the productivity and so forth. So I'm just wondering if there's any value in contacting, let's say, the companies such as Columbus Corporate Gold, if they operate over there on the coast, and seeing what the appetite is for an occupational health program within their companies to add a little bit more insistence. There's no magic bullet here. Everything you're trying is good, and there is an effect. There's incremental benefit. So the first thing to say is congratulations. You've got to keep going, and you've got to keep using different elements as well. And together as a community, hopefully we can start to have that impact. So it's just a comment there. Thank you. Thank you very much.
Thank you. I'd just like to say that with the Global Fund and the PAHO, we are working on transition and sustainability because we know, of course, funding will decrease and eventually possibly stop. But we are still very much dependent because of our complexity of the risk population on external funding. And one of the things that is going to happen very soon is for us to make an investment case for the malaria elimination and hopefully attract also more investment from the private sector. Yeah.
With that said, thank you very much, Helen. Thank you.